this
Sorry, yeah, carry on.
this yeah this scan was done almost on day 14 of life. Okay, so I'll find the coronal view. This is like C1, where is the orbital ridge, and there is dilated ventricle actually showing from here.
Correct.
Okay, so I'll go down. Okay, okay. This is actually the view, like it's like C2. You can see like there is dilated ventricle here, and there is I don't know, doctor. This is or hematoma or dilated ventricle or something here. I cannot see. I cannot yani, judge
Yeah.
what is that.
So it's parenchymal infarct, and it's a venous infarct. It's basically a grade 4 IVH.
Yeah.
So it's a very nice, not a very nice image for the baby, but yeah, it's a very nice image, which basically shows both your lateral ventricles. And this ventricle basically has what appears to be a large hemorrhage both inside the ventricle. But
Mm.
just remember that this hemorrhage doesn't originate inside the ventricle, it's because of venous congestion. So, yeah, I mean, the image quality is very good. You've got a very nice, I would say, use of your depth in that your image is filling the whole screen, and I can see the whole of the cerebral hemispheres, and clearly, the third ventricle appears dilated here.
Dilated, yes,
Yeah.
here.
So carry on.
Yes. Again, I went like to C3,
Yep.
but this is the thing. Here, like when where is like the brain stem and the medulla and
You won't see them.
everything's like it's I don't know, it's mixed, like everything is gone by the infarct, so it was difficult for me to interpret.
Yeah, just grossly. The important thing is we don't want to look for the minutiae, and the brainstem will be very difficult to kind of see in this particular view. You'd
Mm,
have to go further back, and really the best views to kind of look at the brainstem are really trying to take the cerebellar views when you look at the mastoid and temporal fontanelles. So don't be too worried. Again, you've got a
mm,
beautiful image in the midline. You've got dilated lateral ventricle. Both ventricles are dilated. Here, the clot seems pretty much to be intraventricular, and these are
mm.
temporal horns that are dilated. And again, you're just getting a small view of the third ventricle coming in there. So it's a very good image. There's also, for those of you who have a sharp eye, midline shift. So you can see that the interhemispheric fissure is kind of pushed to the opposite side. So carry on. Very nice image.
Okay. Then I went back, but it's like showing more only dilated of the ventricle, dilation of the ventricle, and at the same like hematoma.
Yep.
And then I went back, like this is, I think, the body of the ventricle, and it's the same almost.
Yep. It's quite a large grade 4 actually, and it extends into the area of the trigone quite significantly into the hemisphere. So yeah, it is a little bit worrying. Carry on. Yeah. Image quality is very good. Yeah.
So
Hmm.
suppose that I'm in the like doctor, I'm the like C6, but still I'm seeing part of the ventricle. So is it because of it's dilated or I
Yeah.
don't know.
It's because it's dilated. What has happened is the occipital horns of the ventricle are dilated, and you see that clot, which is starting to degenerate and undergo cystic change.
Yes,
And
here.
eventually, there's a very high chance this will develop into a porencephalic cyst. It will break down completely, and you'll basically see a hole in the brain. So, yep, you've got all six views there. Well done. Very good. And that's your midline view. It's never
Midline view,
easy.
yeah.
Yeah. So again,
Um,
yeah, carry on.
the thing is the corpus callosum is thin here or with طبعا dilated ventricle, and you can see all the like the ventricle is dilated. The third is cleared. Um, يعني the ventricles dilation is clear.
Yep. The question is whether, from our perspective, you have had some clot, which is causing back pressure here, which is causing the lateral ventricles to dilate. But the good thing is your vermis is clearly visible. Fourth ventricle is not collapsed. So there's definitely CSF moving between the third ventricle and the fourth ventricle. And that at this particular point would bode well for this baby. You'd hope that CSF can still drain into these spaces and then basically into the foramen of Magendie and Luschka and then get absorbed by the arachnoid villi. So uh, it's a great image. You're just a little bit further forwards. You want to try and get your corpus callosum into the center here, but obviously it can be challenging if a baby's moving. Your corpus callosum is very thinned out. What was the gestation at birth?
32 weeks.
And now corrected gestation?
Now he will be 34 week plus I think 3 days like this.
Yeah, so you're basically going to undergo a white matter change. And when you have white matter change, one of the changes of white matter injury is basically a very thinned out corpus callosum, which is poorly developed. So you might be seeing some of that at the moment. So it's a good midline view. Carry on. I can see the cerebellum as well. Yeah. Yep. Now you're going towards one side, and that's probably the right side because you can see massive amounts of clot in it.
Yeah. Um, Actually, I forget to to write if it's right or left.
No problems. My gut feeling is this is somewhere between the midline and the right because you've got clot, but you can see corpus callosum at the top there. So it's kind of somewhere in between. Well done. Very nice image. Unfortunately, not so nice for the baby. Well done. So good
Okay.
images, good depth. I think your gain settings are perfect. Because you're showing the images in real time. Uh, and they're not still images. You're seeing classically what we call is issues of uh, temporal resolution. And really, once you store the image as a still image, the clarity becomes much better. But very good scan, very nice scan, Dr. Noor. Not so nice for the baby.
Oh, thank you, doctor.
God bless you.
Thank you.
Hello, can I stop?
Yeah,
Can I ask a question?
please.
The first picture C1, I think that how we can understand that it's venous
Infarct.
infarct.
Okay.
Yes, not arterial infarct.
So all grade 4 infarcts traditionally were thought to be. Do you want to bring that image up again, Anud? If you are able to share it, it would be beautiful. I can explain to Sevinj. Maybe not. So when you have a grade 4, and I will be talking about this on the coming Sunday, a grade 4 IVH extends into the parenchyma as well as into the ventricle. And
Yeah.
previous thinking about it used to be that the bleed goes into the ventricle and basically then bleeds into the brain. But actually, when I talk about the pathophysiology of grade 4 IVH in particular, it is usually venous obstruction secondary to a combination of cerebral edema in that zone, alongside the fact that the capillaries being extremely fragile break down
Mm.
and cause the venous, the venules to basically become very congested. Now, that back pressure is eventually what leads to the parenchymal kind of change. Now, initially, when you have the infarction,
Mhm.
on MRI, it will appear hypodense. But when we resuscitate the baby or when things settle, you'll eventually have an element of reperfusion injury. So blood will enter into the parenchyma because of
Mm.
reperfusion, break through
Mhm.
the kind of capillaries and the venules and accumulate and give a very bright appearance. So that is why it's called a parenchymal ischemic infarct. And we classically call it a PIVH, parenchymal ischemic venous infarct. So
Mm.
it's ischemic to start off with, but then because of hemorrhage within it, you get the bright appearance. The etiology is always venous.
Mhm.
I will be able to show you some images of where a baby has had hemorrhage into the ventricles and then into the parenchyma. There's some telltale signs that that might be the case, and that is possible, but it's not common.
Thank you very much.
Any other questions? Okay, Nashwa, you able to share?
Yeah, I can now. Yeah. This is a term baby, 38 weeks. This baby diagnosed antenatally by NIF test as a trisomy 13. So he was, since birth, he was a decision for DNR for this baby. But I was curious to know what is the brain abnormality was inside. So I did a scan for this baby just to know if anything is abnormal. So this is the coronal view. As shown here, it is the ventricle is dilated, the lateral ventricle.
Yep.
Here and third ventricle also dilated. Here I didn't able to see the corpus callosum.
Well done.
Yeah, and it is the more posteriorly. Here is the midline, the mid sagittal. Also here, يعني this is يعني the I was able to can see here the corpus callosum at all. Even يعني I was able to see
So
the mid sagittal, but it didn't come with me at all. The corpus callosum here in this
uh,
slides.
it's there's marginal visibility of the body of the corpus callosum, but anteriorly I can't see it at all, and posteriorly I can't see it well at all. So you're absolutely right. I mean, a
Yeah.
corpus callosum agenesis, a partial agenesis, is a very high likelihood. Very nice image, good depth. My only comment is gain settings a little bit on the higher side. So you
Yeah.
probably just want to drop your gain settings a bit, but good depth, good penetration, and I mean you've got the whole brain. Well done.
Yeah. And what about the sulci here? Because I feel like also it is a little bit smooth, even he was
It
term
is.
baby.
I
Yeah.
agree. I agree. Very poor maturation. When you look at it in terms of smoothness of the brain, sulcal gyral maturation is extremely poor. What do you think about the basal ganglia?
Mm, it's a
So,
little bit hyperechoic.
yeah, I think when I look at some areas here, in particular this area, looks a little bit hyperechoic. Some of this might reflect your high gain settings, but this area
Mm,
does look a little bit hyperechoic. But the ventricles look clean. You've got a bulky choroid. Again, a very nice image, but very poor sulcal gyral maturation. A very smooth brain.
mm. Yeah. So this
Similar.
is yeah. So this is the finding that I found in this baby. Yeah, and I didn't do detailed scan, but
Sure.
I just want to know if any abnormality is there. So
Can we go back to your first image? So this is a very classical appearance. We go back to the image before this of the midline, and there's no corpus callosum kind of connecting. There's a just the body is visible, but there's partial agenesis over here. And for that reason, what you've got is you've basically got these ventricles being quite splayed. And this is also, some people call it the inverted teardrop sign. So if you turn it around, it looks like tears. These look like tears.
mm.
So a very kind of classical description. Uh, there is a little bit of corpus callosum visible. I'll just show you exactly where. So just over there, you can see. And as you move forwards, so if you just go forwards to your next image, it completely,
It is not shown at
yeah,
all.
yeah, yeah. And I mean, this is further back. Let's go back to the previous image and the one before that, just front, further in front. Did you take an image before? No
No.
problems. It's okay. That's all right. This is good enough for us to make a diagnosis. Very good image quality, very good depth. I can see really nice Sylvian fissures at the side over here. And again, I'm just a little bit concerned about the basal ganglia regions looking a little bit more bright. The question from my perspective is whether the gain settings might be slightly on the higher side because the cerebrum also looks bright. Now, how do I know gain settings are high? A really good way of looking at your gain settings is to look at your bone. And if your bone kind of gives what is called a luminous appearance. So can you see a luminous appearance? It's like a light. Then you really know that your gain settings are slightly on the higher side. So that's the only thing. Your focus, again, it's really nice. It's at the level of the ventricles. So very nice images. Well done, Doctor
Yeah,
uh,
thank you.
Nashwa. Save the image. Just for those of you who, I am doing logbooks this Sunday. So I've already started. On Sunday, my humble request is don't add any extra images on Sunday. If you take any scans, start adding them from next week. For those of you who've completed 5 scans, I will be putting your L1 certificates in. Just remember, you have to have completely watched the first 4 videos up to the protocol. I will capture that through your interaction with the module. So if you've not done that, then please try and see if you can finish up to the protocol video, and then I will give you a certification for L1. So Nashwa, you've definitely done that. So for those of you who are ready to have their L1 certificates, you're ready to move on to L2. So well done. Very good.
Thank you.
We have Dr. Hassoun. Dr. Hassoun, are you able to share?
Oh, yes. Good evening.
Good evening.
Okay.
So Dr. Anu, don't forget to upload your scans because I'll be signing your logbook.
So I'm
Brilliant.
audible and visible.
Audible and visible.
So just I try, this is my first scan cranial ultrasound. So just I will present this case just to see if I'm getting the good views or not. But there is no pathology in this scan. So this is 33 weeks, twin one C-section. Just he was on CPAP for 24 hours, antibiotics for 48 hours, and I did the cranial ultrasound by day 3 of life. So
It's brilliant.
okay, so this I put the depths as we يعني, agree 7 centimeter and the focus little bit on the interhemispheric sphere, so fissure, and this is C1. So here what I saw they like to blush, but this is normal I think.
Completely
And
agree.
this is the orbit. Okay, and when I move to C2, still so I starting the يعني corneal anterior part of the frontal horn start to be up to I saw here little bit here so small, and still also the blush here.
Yep.
So I think also it is normal.
Correct.
So this is C2, and my frequency is 7 hertz.
Brilliant.
So C3 here I start to see the corpus callosum, lateral ventricle, and the septum pellucidum, cavum septum pellucidum. Here I don't see the third ventricle if I'm right.
You're right. You don't see it there, but your next image, you see it very nicely. So
Yeah, here, yes. So
yeah.
here I got it. So here we have the 2 ventricle, but like collapse the ventricle. I didn't see any. It is not like a normal ventricle with CSF.
It's a term baby. So often ventricles will be quite small, but
So
brilliant
this is the
image.
third ventricle, sir. This
That's
is the one.
correct. That's correct.
And here we are starting to see the pons. Okay.
Yep.
Okay, and here also the corpus callosum.
Correct.
And little bit on C4 or C5. This one I start to see the cerebellum.
Yep.
Third ventricle, I think this is the one.
That's still the
Or no?
cavum, the posterior part of the cavum, septum.
Okay.
So the third
Okay.
ventricle wouldn't be visible in this view. This is classically what we call the trident view. So just because it's such a beautiful image, can you see how you get a trident view? Like you have with Aquaman. We also call it the Trishul view in India. Very nice image, beautiful. You're just getting, white gray matter differentiation. Now, my only comment is we're just losing the back of the brain.
Yeah.
So we just have to basically reduce our depth a little bit so that we can get the whole of the brain into the image.
Okay.
Yep. But it's a beautiful image. Brilliant.
And here I think this is the trigon.
Yep, that's correct.
So I thought so this is also like
very nice
loop. Okay.
Yep.
So this is the trigon, and also, but all this, Dr. Alok, all these blush are normal, صح? Or
yes, this is no, this is normal blush. It's very symmetrical, very geometrical. Pretty much the same areas. I think your gain settings are appropriate. It's very much what you'd see. So
okay.
Yep.
So last one, I think here's a occipital horn.
Yep.
here also this one I like a drop out. So this is also again from you should adjust the gain here.
So you can try and adjust the time gain compensation in the lower part of the image. Again, by moving it to make it get a little bit more gain, maybe reduce your gain a little bit in the upper part of the image. But otherwise, for me, this is perfect. It still looks normal. I can see
Okay.
choroid with basically the trigonal view and the occipital horns.
Okay. Okay. And this is, I think, the last one here on the left, on the occipital horn.
Brilliant.
Okay. And when I went the mid-sagittal, this is the mid-sagittal. So I think here the corpus callosum, cavum septum pellucidum, third ventricle, and here I think the third ventricle here, sir?
No, that's the prepontine. That's a prepontine cyst. So if I
Okay.
draw it for you, absolutely fine. So this is basically your ventricle. It's then basically connecting here through the
Yeah.
third ventricle. And then you come
Okay.
to the cerebellum. This is the fourth ventricle. And this is the entire ventricular system that you see over here. This is the
Okay.
pons, and this is a small prepontine cyst. This may or may not be seen in term babies. It often gets absorbed, but if it's present, it's of no clinical significance.
Okay. This is what I confused. What is this one? What is this cyst or ventricle here?
Yeah.
Okay. Fine. Fine. Thank you. So and then I went right. Here there is codothalamic groove is fine, and just here I think it's the dropout, huh?
Little bit. It's a little bit of dropout, and nothing that would worry me if the baby is completely normal and you have no history. That would
Oh,
suggest the baby's had hypoxia ischemia. So a very nice image again. This is your right side. So
yeah.
and this is going to be tricky because this baby has very small ventricles. So just for everybody, you are not going to be able to get the full C like you get in preterm babies. So don't feel too anxious about trying to get that.
Okay.
But what you want to do is you definitely want to get this out of view, which is the corpus callosum, because you're somewhere in between. So that will come. Don't worry. The image is
Okay.
beautiful. Yeah.
So and here I think a little bit
Brilliant.
I went left.
Brilliant.
So a little bit right, but I saw here is a choroid plexus, and it's
Yeah.
fine, I think.
Perfect.
And here's the most lateral part, and then I went. This was the one left. This one.
Yep.
This is the one most the choroid also plexus on the left side.
Yep.
Here I tried to do one mastoid axial, but I cannot interpret it. So this is the one I did it. So, but I don't know what I saw, what I see on this view.
It's a little bit tricky. My gut
Mm.
feeling, if I have a go at this, is that you're probably seeing the temporal lobes coming in here and the cerebellum starting to appear. And if you just play it
Okay.
again, you can
I
see that.
I got another one if you want,
Sure,
Doctor.
sure. Oh, brilliant. Yeah, very nice.
Okay.
Yeah.
This is one I cannot interpret it. If you can help me.
Yeah, sure. Absolutely fine. So basically what you've got is this is probably a part of the midbrain. This is what we call is the fourth ventricle coming into view over here. Depending on your depth, as you go down, what you'll find is you go into the brainstem, and if you move your probe up, what you'll find is you'll get more of a cerebellar kind of a view, and this is really cerebellum. So you've moved up over here, your fourth ventricle has disappeared, and you can see that kind of pattern that you get with the cerebellum, which is what we call like a ciliated pattern. This is basically one of the cerebellar hemispheres. Were you doing it from the left or the right?
From the right.
So
Sorry,
that
from the
is
left.
from the
From
left.
the left.
So that is basically the left cerebellar hemisphere. This is the cisterna magna coming into view at the back there.
Can you just annotate, Dr. Albert is not coming. If
My
you are
apologies. Yeah, sure.
yeah.
I'll just take my drawing. So this is basically the fourth ventricle. This is
Okay.
probably somewhere between midbrain and cerebellum.
I can
But
play it if you want.
yeah, this is definitely cerebellum because you've got the ciliated view that you see. Can you see how you got the ciliated view at the end?
Oh,
Cisterna
okay.
magna that you start seeing,
Oh,
which is always associated with the cerebellum. This is basically a small area of the kind of fourth ventricle that's coming into view. The other cerebellar hemispheres coming in over here. It's not
okay.
unusual when you have small windows to be able to see the ipsilateral cerebellar hemisphere very well, but not be able to see the other. But once you get it, really what you want to do is you want to do measurements, and I'll be talking about them. in a class going forward. And really, with your measurements, really what you're doing is measuring from one end of the cerebral hemisphere to the other to get the measurement in millimeters. And that correlates with gestation age. So if you have a kind of a 35 millimeter cerebellum in this baby at term, that would be appropriate. But if the cerebellum extended only here, then that would be an indicator of cerebellar hypoplasia. And again,
Okay.
the importance of doing cerebral images, and I'll talk about that on Sunday, is making sure that you don't miss a cerebellar hemorrhage in the cerebellar hemispheres, because you can get isolated cerebellar hemorrhage with normal ventricles with no IVH, and that has significant prognostic implications for preterm babies. Very
Okay.
nice image. I mean,
Okay. This
brilliant.
is just the last one. I think this is perpendicular, yeah, not axial one.
Yep. And again, just the fourth ventricle seen very nicely. You're seeing the cerebral hemisphere beautifully. Can you see that ciliated view? That is classical cerebellum.
Yeah. Okay.
That
Okay.
ciliated view. And actually, with the eye of faith, you can get a measurement there. So that's a brilliant image. In terms
Okay.
of kind of your lobes, it's very important to kind of know these are the temporal lobes that you see over here. So I'll just annotate that again. This is the temporal lobe. This is a temporal
Okay.
lobe. And this is basically one of the ventricles coming in. So it's not dilated because this is a term baby. So that's why you're not seeing it. But this is a brilliant view to see the cerebellum. And it looks absolutely fine. The ciliated appearance at the margins looks bright, and this is normal intensity. If you see this kind of brightness in the center, that would
Yeah.
indicate a cerebral hemorrhage.
Okay.
So
Okay.
brilliant image.
Thank you. Thank you very much.
Thank you, everyone. Nice cases. So we saw initially a grade 4 IVH today. We've seen absence of the corpus callosum, and we've seen some really nice normal anatomy, normal scan in a baby. So what I'm going to do now is I'm going to introduce our expert speaker for the day, and it's Dr. Ranjit Gunda, who is currently a consultant working in a Halia hospital in uh, Musafa in Abu Dhabi. He's a very close colleague, a person who has worked with me for at least 2 decades, and very, very, very good educator who has got very long history of being able to run multidisciplinary medical education simulation. Uh, has and runs the difficult airway course in the Neonatal Sim instructor course with me, but also has a special interest in point of care ultrasound. And today I will be asking him very kindly to speak and give us an introduction into hydrocephalus, specifically congenital hydrocephalus, but speak to us about certain brain abnormalities that we haven't covered early in the course. So I will hand over to Dr. Ranjit, mute myself. Ranjit, you can share.
Thank you, Alok. Thanks for the nice words, and good to see you again. And Dr. Hassan, Dr. Nashwa, and Dr. Anut, I think you have brilliant. You're doing very good, actually. Your images are much better than what I see now currently in my presentation, which is very good. I think it's adds from the story what you have built up in the last half an hour. So what I'm going to talk, we're going to discuss today, and Alok also can probably step in and chip in various places. Let me start sharing my presentation first. Can you see my presentation there?
Yes, audible, visible, just needs to go into full slide mode.
Better?
Perfect.
So good evening, everyone again. I'm Ranjit Gunda. I'm one of the consultant neonatologists and trained with Alok and trying to learn more and more every time I see him. And yeah, we'll start from here. So probably after seeing your standard of scans, probably I can skip first 1 or 2 slides. I don't need to spend much time on that one. So basically, we're going to talk about if you see dilated ventricles, ventriculomegaly, how to measure them. We're going to say it's hydrocephalus, and based on the science and measurements what we see, when to intervene, what to do, what does the guidance say, and see if there are any congenital cerebral anomalies that can be associated with it, and to try and summarize things together today. So when we see ventriculomegaly, like the second scan shows us a beautiful example from Dr. Nashwa, where the ventricles are slightly dilated. Then the question comes, is it in normal range? Is it something abnormal? What do we need to do about it? And when to go from there? And to make it more easier and clearer, I think lots of work has been done in this place, especially looking into some objective measurements rather than being subject to it slightly bigger, less bigger, or smaller like that. So we're going to look into some objective measurements that will guide us clinically to see whether we need to intervene or whether we need to monitor it more closely and how to do it. And to try and differentiate it from communicating and not communicating hydrocephalus. And we'll see. So obviously ventricular dilatation secondary to disturbances in the CS of dynamics that causes the hydrocephalus. Normal coronal views, beautiful pictures from Dr. Masood, if I'm right, the last one. Beautiful pictures we have and good examples of normal images. I'm not going to spend much time on them. So a little bit of asymmetrical ventriculomegaly is common in preterm infants. Again, if you see a picture like that, as you can see in this, probably a C3 view coming into where the left ventricle is slightly on the bigger side. If you are worried, we can do some measurements that will help us guiding whether it is dilated or not. But generally, this part of asymmetry, prominent left lateral ventricle on one side, especially more common in the left ventricle is more prominent, is common in preterm infants. And then, so question is, if we have ventriculomegaly, then the question is what measurements we need to do and how do we go about it? And your examples today are very good at starting it. So first we go with something called ventricular index. Also, terminology says Levine index, ventricular ratio. Various terminals have been used for this thing, but typically best way to use is ventricular index, which is measured in the C3 view, which is mainly the level of foramen Monro in the coronal view. So measuring from the midline falx to the lateralmost part of the lateral ventricle. That is the measurement we wanted. So doesn't matter whether you take here or here, but it has to be from the midline falx to the lateralmost part of the ventricle. So that is measured in millimeters. That gives us the ventricular index, also called Levine index because Levine is the first one who described it in 1981. It's a marker of ventricular dilatation and increasing ventricular volume. Only problem with that is it might not be the first sign of ventricular dilatation or development of hydrocephalus. So there might be a slight other signs which we'll talk through when it comes to ventriculomegaly. And the normal values of this ventricular index also changes with the age. So good normograms have been developed by Levine, which has been for the last 40 years has been followed across the world, and all the literature work has been okay. Another example of how to measure. So as I said, we don't have to exactly measure in the line of where is the maximum. We just need to make sure that we are in the C3 view. Here we just, as you can see, the trishul view or trident view, where the two ventricles are draining into the third ventricle here, and two Sylvian features in the middle. That tell you that you're symmetrical and in the right view at the moment. And measuring from the midline to the lateralmost part of the ventricle. It can be done like this as well. So just giving various examples how we measure it. So again, coming to the normograms, we have this articles I can upload in the Dropbox for you. I won't be going into very details into the management point of it. So basically, although we thought of talking about congenital hydrocephalus today, the measurements, most of the hydrocephalus that we are going to treat and intervene mostly comes with the post-hemorrhagic ventricular dilatation. So my talk, like our discussion going today is going to be overlapping between the both. So we have normograms like this, which was described by Levine and ranges from 25 weeks, start from 25 weeks gestation up to 45 weeks. These normograms are more of useful until 33 to 34 weeks. After 34 to 40 weeks, still not much research is available in terms of intervention on its own. Ventricular index is not the only indicator what we need to do, but we need to take a combination of measurements and the clinical picture together to do it. So the nomogram, as we say, sees as a third centile, 50th centile, and 90th centile. And if we go a bit more detail into the gestations, so anything basically, if a ventricular index is more than 10, irrespective of age, we should start suspecting it's on the higher side. Then we should start looking into it a bit more closely and detailedly and do a bit more evaluation into it. When to start intervening into it, and the same, again, Levin and Leo also has been doing the same normograms up to 42 weeks of gestation. As you can see, both these normogram lines are pretty similar, following the same pattern. So, as I said before, it only starts increasing in the lateral part, fails to identify the initial mild dilatation. So the early signs is generally the change in the shape, ventricular shape starts ballooning up first, rounding of the frontal horns. If you look into the first picture, second, Dr. Naushin's images, probably if we get a chance at the end of the presentation, we can go back to them again. And rounding of frontal horns and increasing in the anterior horn width are the two early signs that might be helpful to suggest there is a ventricular megaly compared to ventricular index. So then again, when we measure and we plot on this normogram charts, the main clinical indication that that question comes to us is when to intervene and what to do. So basically, if it is 4 millimeters above the 97th centile, so basically this is centile, so anything about 14 to 15 up to 19 in the term baby. This is like a 97th centile. This is the 4 millimeters above the 97th centile. This is the cutoff for the intervention. So if the ventricular index crossing this line, we need to start doing some intervention to preserve the pressure effect from the ventricles onto the brain parenchyma. Okay, other terminology, again, Levin index is in the literature, if you look into, they use quite reciprocately, Levin index, ventricular index ratio. The few slightly different. Generally, most of the literature, if you see, in the preterm infants, it's more called ventricular index. More towards a term baby, it's called Levin index, but they both are exactly same. There's no difference in between the both. But once it comes to ventricular index ratio, is slightly different, where it is measurement of the ventricular diameter along with the biparietal diameter. So basically taking from the midline into the lateral part of the ventricle, and also the biparietal diameter from parietal to parietal. So here again, ventricular index ratio for in the early 90s has been looked into more effective measurement for looking at the ventricular megaly, but latest research after that showed ventricular index, not the ratio, is more relevant for us. So we stopped doing it on a routine basis. If I'm right, Alok, you can chip in here before I move further. But ventricular index is something that we routinely take on rather than ratios. So here saying normal is less than 0.3 in the ratio, severe is more than 0.4. But normograms are mainly based for the ventricular index, not for the ratios. Other terminology looking at the lateral ventricle measurements is the what we call ventricular axis. The same C3 view, or sometimes you can do in the C2 view as well, where the vertical dimension measurement of the ventricular axis. People have started looking into it. Actually, doesn't have much literature into it, doesn't help much in our clinical management. But if you come across the terminology of ventricular axis, this is the one that we can measure from the lateral part of the from the diagonally in the vertical axis of the lateral ventricles in the C3 view. And other thing that we come across is the ventricular height. It is done in the parasagittal views, the level of the chordothalamic groove in the first parasagittal view, where we get the C-shaped ventricle and the measurement of the height of the ventricle. Both the ventricular axis and ventricular height are not, we don't have many normograms that we can compare with, but that might help us to monitor if you're doing serial scans to give us impression exactly which part of the ventricle is increasing or not. But again, these are the measurements that we can come across in the literature, or that might be helpful to serial monitoring of the lateral ventricular measurements. So another thing which mentions the ventricular ballooning. As we talked about, the ballooning of the ventricles is an initial very early sign that comes out in the ventricular megaly, developing into hydrocephalus. So ventricular ballooning followed by temporal occipital distance, followed by anterior horn width, which we are going to talk soon, or the early signs. Later only we can see the rise in the ventricular index. So I think so far, I think we covered anything. Alok, we want to add in this stage. This is the measurement of the lateral ventricles in particular. I want to everyone to be clear about. Any questions in that here, I will probably want to take before move on to the next measurements that we go on to.
Can I ask about the VH, ventricular height, or
Yeah.
in the parasagittal? So for that, there are no normal values. That's for serial measurements.
No normograms for this, but you can use for the serial measurements.
And it's in exactly the same view as the thalamo-occipital diameter.
Same use of occipital distance, yes, but we measure at the level of the chorothalamic groove.
Thank you.
Okay. So yeah, that's a measurement. So from the lateral ventricular measurements, the most important thing for us will be the ventricular index, ballooning of the ventricles. These are two important things for us that will help. Next, come to the next measurement in the lateral ventricle, that is anterior horn of the lateral ventricle. So we want to look at in the coronal view, again, preferably at the level of foramen of Monro. Here, okay, and C3 again. Here we'll be checking the diagonal measurement of the ventricle. This is more sensitive marker for ventriculomegaly compared to ventricular axis. Ventricular axis, as we discussed, it's measured in vertically like this. This was a diagonal measurement of the ventricle. Here you can see starting of the ballooning a little bit of the lateral ventricle. And also here the measurement we want to take, what is the maximum diameter you can get in the measurements here. Diagonally is the most sensitive marker for initial ventriculomegaly that will start for either in the posthemorrhagic ventricular dilatation. But if it's a congenital hydrocephalus, probably you might not see the slow progression. You might directly see a baby with big ventricles because there might be a congenital anomaly associated with it. But these measurements and serial measurements will be more useful for us for the posthemorrhagic or progressive ventricular dilatation because of either because of hemorrhage or infective pathology that we'll see. Again, for the anterior horn width, so best place to measure will be C3 view, where the third ventricle just coming into view. Make sure that both sylvian fissures are in the view for you, and then you take the maximum measurement of the diagonally of the lateral ventricle. So this is the ventricular index we'll be talking about. This is the anterior horn width. So again, we have good nomograms for the anterior horn width, mainly described by the Davis and the group in early part of the century. So again, we have centiles 3rd, 50th, and 90th centile. The action line again, when to intervene comes if it is more than 1 millimeter above the 97th centile is one indicator, or other ways people take into if the overall measurement of the anterior horn width will be more than 4 mm, which will be coming somewhere here. Okay, so both of them pretty much we're talking about more than 1 mm above 97th centile. Similar work. Okay, so quite simple, giving it simple, anterior horn width, early marker, diagonal measurement at the C3 level that will help us to identify early ventriculomegaly. And we have nomograms that can help us in deciding the management pattern. Next comes to measurement of the thalamo-occipital distance. So again, lateral ventricle, the posterior horn, occipital horn. So parasagittal view at the level of the ventricles, the C shape. What we want to measure from the distance from the thalamus to the posterior wall of the occipital horn. The maximum distance wherever you can get from the thalamus to the posterior wall of the occipital horn. As you can see, the measurements here. Again, thalamo-occipital, first sign generally we see is balloon dilatation. Second is slight increase in the thalamo-occipital distance. Third thing is anterior horn width. Then we see the change in the ventricular index. There's a sequence of things that happens if it's a progressive ventriculomegaly that we see in the ventricular dilatation that happens because of the pathology. Again, we have the nomograms from the babies group. Again, the same. Here, so we have same 3rd centile, 50th centile, 97th centile. Again, to describe either it should be more than 1 mm over the 97th centile, or overall measurements more than 26 millimeters, which is above the nomogram here. So either you then is the plan to intervene and or monitor closely, and we need further imaging, whether to drain or whether we need to have some sort of management actions for this ventriculomegaly. So we sort of finished the lateral ventricular measurements. So ventricular index, anterior horn width, and then the occipital distance are the 3 nomograms, which are very well described, which are very much used across the world, and quite objective measurements, useful for serial measurements and making a management plan for the infants that we see. This comes to the how we measure the 3rd ventricular width. So best way we can do in either coronal view or mastoid view at the level of foramen of Monro. So it's horizontal measurement of the ventricular size of the 3rd ventricle. It comes in millimeters. If it is more than 4 mm, it is significant in terms of intervention. So coronal view will be looking like this in the C3, and again similar example, measuring taking the maximum diameter of the 3rd ventricle that you can see in the C3 view. This is the mastoid view that we will be seeing in the horizontal mastoid view. Again, you can measure the horizontal width of the 3rd ventricle. If it is more than 1 millimeter above the 97th centile, or more than 3 millimeters in total depth, is the 3rd ventricular width is significant. So the measurements, we again coming to ventricular index, anterior horn width, occipital distance, 3rd ventricular width. 4 we have covered so far. So just to summarize, so far what we have discussed, so ventricular index, most widely used, more than if it is more than 97 centile, above 4 millimeters, then it is significant, measured the coronal view and at the level of foramen Monro. Anterior horn width, again more than 4 millimeters in actual number, or more than 1 millimeter above the 97 centile. Occipital, either it is more than 26 millimeters is significant, or more than 1 millimeter over the 97 centile. 3rd ventricular view, more than 3 millimeters in size, or more than 1 millimeter in the 97 centile. So these are four common measurements that will be helpful for us to go further. So same thing. Again, one other thing I want to mention is the mastoid in the 3rd ventricle, and we need to do the measurements from both sides of the mastoid to make sure that we are exceeding the limits. Sometimes if you do one from one side, the measurements might not be as accurate. So whatever the measurement that we get, it should be measured from the both right and left side for the 3rd ventricle, and even for the 4th ventricle. 4th ventricular width is not very common to see, but again, it will help us to identify communicating, non-communicating hydrocephalus and any cerebral pathologies that will also congenital pathologies that might be born with. It's best viewed in the mastoid view. It's in the vertical view. So it's again horizontal measurement of the ventricular size. This one. The width is important. Again, not much normograms available here. But if you look into the things more than 1 mm above the more than 3 mm, like the 3rd ventricle, becomes significant for the 4th ventricle as well. So just a little bit of example, ultrasound of a preterm baby on the day 8 of life, bilateral, we have the C3 view, symmetrical picture, and we have the bilateral grade 2 to 3 bleeds, with ventriculomegaly grade 3 IVH. IVH will cover slowly by Alok in the next lectures. So here you can start seeing the balloon dilatation a little bit. And occipital is also slightly looking bigger. We don't have measurements here. Again, more and more balloon dilatation that you are seeing, rounding off, and occipital getting more and bigger, and here. So you can see the progressive, by looking at the picture, yes, it is obvious for us there is a ventriculomegaly, but having an objective measurement of all the indices that we talked about will help us to see when to intervene, how frequently to scan, do we need to do lumbar puncture, do we need to go for surgical intervention? These things will guide us in terms of the measurements for us. So now we sort of learned how to measure. So we have a patient with us with ventriculomegaly. Then the question comes, is it actually ventriculomegaly or something else happening in the parenchyma that's causing looking like ventriculomegaly or hydrocephalus for us? So we have two situations where we have ventriculomegaly, the slightly bigger ventricles here, and the slightly enlarged ventricles might be starting of the ventricular dilatation here. We don't know. So one of the way we need to think about is ballooning of the ventricles. It's happening. So there is some ventriculomegaly happening for us. And we need to measure the ventricular index to see how big it is. But also we need to differentiate, is it because of the ventricular pathology, the bleed inside that's causing the problem, or in the parenchyma that's causing the problem? So when ventricle with convexity happening towards the ventricle here, the angle here, that's towards the ventricle, that more towards the problem is internal pressures that's causing the problem. So it's a post-hemorrhagic ventricular dilatation that's causing the ventriculomegaly. Here the concavity is towards the outer side, and it's basically what we call hydrocephalus ex vacuo, where the surrounding parenchymal tissue is damaged, and that's why it pulls a negative pressure to cause the ventricular dilatation. So it is useful for us to differentiate between these two. It might not be that easy to say sometimes. Other markers that will help us to see is the intercerebral fissures here. So as you can see, if it is quite approximate together, that means there is the parenchyma is preserved and there is no loss of the arachnoid space here. But if you look into this picture, there is intercerebral fissure is very prominent. That tells us there is a loss of the brain parenchymal tissue that might be contributing to the ventriculomegaly here. So when we see ventricular dilatation, these are the things that we need to be watching along with the pathology, pathophysiology, what we might be dealing with along with it. Again, the other thing is, if you see other ventricle, third ventricular dilatation along with the ventriculomegaly, is most likely the problem is in the ventricular system compared to its only isolated ventricular dilatation. Problems, it could be ventricles itself, or it could also be the parenchymal problem like hydrocephalus ex vacuo. These are one differentiation that we need to think about when we see ventricles. That's the first question we want to ask. Is it internal ventricular CSF drainage problem, or is it because of the parenchymal problem that we see the ventricles slightly enlarged? Next question comes, what type of hydrocephalus we have, whether we have a communicating or non-communicating, which is also called obstructive hydrocephalus. So if you see total ventricular system is dilated, which means the ventricular index, anterior horn width, pterymo-occipital distance, third ventricle size, fourth ventricle, all are dilated. That means there's a free flow of CSF across the ventricular system. That means it's a communicating hydrocephalus. If it's only lateral ventricles are dilated, or only lateral ventricles and third ventricle is dilated, but fourth ventricle is not dilated, then we might be dealing with obstructive hydrocephalus, in which case it would be associated with the congenital anomalies or secondary to IVH that blocks particular part of the, either in the foramen of Monro or aqueductal stenosis that we might be dealing with. So again, looking at the whole ventricular system, then guides us to tell whether we are dealing with communicating or non-communicating hydrocephalus here. So the first question we want to ask, is it ventriculomegaly? Second question we want to ask is it communicating or non-communicating? Then the third question comes, any association with the congenital anomalies? If you're especially talking about the non-communicating hydrocephalus then you might be dealing with the congenital anomalies. So it's not easy to pick up congenital anomalies in the ultrasound scan, but the scan machines are getting more and more easier and crispier images that we are getting, and all of us are getting more and more training, and we are used to it more. Probably we can have an approach in our head where what are the things that we need to look into in all the scans, as Dr. Noda and Dr. Naushin has clearly described in their scans today, which is really good, very much appreciated. That looking at partly all the structures that we want to look into. So one by one, we'll try and see if we can see some examples of it. one of the common things that hydrocephalus is associated with is absence of septum pellucidum or cavum septum pellucidum. You can see here in the midline view, there is no separation between the left and right ventricles. It all looks like one big ventricle connecting the both, and sometimes looks like a butterfly. And there's a flattening of the upper part of the ventricles here. So in various views. So if you see a communicating continuation of ventricles between the two cerebral hemispheres, we should be suspecting, looking at the absence of septum pellucidum here. Okay, it can be associated with septo-optic dysplasias depending on the clinical picture that we have. We need to think of it. It's also very commonly associated with the absence of corpus callosum. Here, actually, we can see corpus callosum, the two lines here. Okay, the corpus callosum we can see in these pictures, but but it can be an isolated finding. Isolated agents of septum pellucidum doesn't have many long-term implications, but most commonly it can be associated with other congenital anomalies and might be associated with hydrocephalus. Also, when you think about Dandy-Walker malformation or have an association with the absence of septum pellucidum. It's sometimes when we initially start scanning, probably in my first year of my first scanning, I saw this image in my first year of my training, and it wasn't easy for me to pick up. I thought it might be just my angle of viewing the scan, but later we realized it's actually the continuation, which is important here, that between the two cerebral hemispheres, that tells us there is no septum. Next common thing that we need to think about is absence of corpus callosum that we come across very commonly. It was beautifully described in the Dr. Naushin's images today, which is, I should say. So again, you can't see the corpus callosum here. As Dr. Alok was mentioning today, there is playing of the lateral ventricles. So normally we want to see lateral ventricles somewhere here. The ventricles, as you can see, quite separated to each other. There's another sign of absence of corpus callosum that we need to see in the coronal views. It might be associated with the absent septum pellucidum as well. Here you can see the butterfly sign along with the absence of the corpus callosum. So one of the important signs is widely separated lateral ventricles. What we say is playing of lateral ventricles. If the ventricles are slightly dilated, it might look like an inverted teardrops, as we saw in the previous picture. If you go to the sagittal, midline sagittal view, so here you can see the normal corpus callosum will have a continuation of the body and the genu and the curve, and then the gyri and sulci are very much parallel to the corpus callosum. But in the absence of corpus callosum, we see this radiation of gyri. Okay, so this is another indicator that tells us that the corpus callosum is absent. Not because of our technique. It might be another indicator that tells us that corpus callosum is absent. Again, we can, if you have a chance at the end of the talk today, we can go back to Dr. Naushin's images. We can discuss, I will look into this a bit more detailedly. Okay, and we also have a situation where there is partial agenesis of corpus callosum. As Dr. Naushin's case has, you can see the anterior part of the corpus callosum, but posterior part is not visible. Okay. So again, here you can see the radiation of the gyri. There is no corpus callosum. So when you look into the absent corpus callosum, it can be associated with absent cavum septum pellucidum. We need to look into the gyral pattern in the midline view, whether it's absent or partial agenesis or full agenesis, whether there's playing of the lateral ventricles. All these are all together helps us to identify if there is corpus callosum agenesis. And is very much associated with other congenital anomalies, including Dandy-Walker syndrome and also septo-optic dysplasias. And all these midline structures, absent from midline, can be associated with other midline defects that we come across, absence of pituitary and gonadal problems, babies presenting with us with hypoglycemias, cleft lip palate. These are all the midline structures we need to be thinking about. So again, another picture of the callosal agenesis. So no corpus callosum, splayed lateral ventricles, and associated with the ventricular megaly, optical occipital distance looks quite enlarged. but there is no continuation of the ventricles. There is no there is no absent septum pellucidum. Septum pellucidum is present here, not visible in this view. Okay, so these are the most common things that we come across in our regular clinical interactions and see. So isolated absent corpus callosum, isolated septum, absent septum pellucidum might not have long-term implications. Generally doesn't warrant regular neuroimaging, further neuroimaging if the baby is otherwise clinically well. But we need to be sure that there is no associated congenital, other cerebral congenital anomalies with it. Okay, next let's go into common association with ventriculomegaly, holoprosencephaly. Basically, it's a anterior frontal lobe malformation. We have one single large ventricle, fused frontal lobes. There is no separation between right and left side cerebral hemispheres here. And the thalami is fused for frontal cerebellum is fused. Generally, it's picked up in the fetal scans nowadays because of the very good fetal medicine team in most of the institutes nowadays. And these sort of babies will need a further neuroimaging. But if we come across a ventriculomegaly, probably one of the things that you want to rule out is holoprosencephaly, which has a very poor prognosis. Example of lissencephaly, it's very similar to what Dr. Noshin's picture again. So wide and shallow Sylvian fissures. There is no gyral sulcal pattern. There is no difference in white and gray matter. Complete idea looks like a premature brain. There is no gyri and sulci. So it's basically very smooth brain. When we do the scans, looks like a 24-weeker, 25-weeker parenchyma as a term baby associated with lissencephaly. It's called lissencephaly associated with hydrocephalus, sometimes missing. And it happens generally because of the ventricular hydrocephalus ex vacuo rather than the obstructive picture of the hydrocephalus. So other things that we come across, things like this, you can see the unilateral dilatation of the lateral ventricle. Again, here, if you want to do, it can be because of the view that we have. Sometimes we see because of it's a premature baby, asymmetrical lateral ventricles is a common picture, but it's in this situation, there's a huge right lateral ventricle, but the third ventricle is not dilated, the left ventricle is not dilated. So it is a case of unilateral stenosis of phenomenon of Monroe. So again, isolated on this just by this picture, we might not be able to tell that, but we need to look at all the measurements that we look into and the underlying pathophysiology, what the baby might have gone through. And there's a midline shift also tells us there is a little pressure from this side of the right ventricle. So Dandy Walker malformation, not easy to pick up on the ultrasound picture. So we'll be looking into enlarged fourth ventricle in the midline view, midline sagittal view. Cerebellar vermis is partial or fully absent. Here we can see a part of it. Big cystic lesion in the posterior fossa. So we have an enlarged fourth ventricle and partial or complete absence of cerebellar vermis and cystic lesion in the posterior fossa, one of the variant of Dandy-Walker malformation, very much associated with hydrocephalus and obviously has significant long-term implications. Want to differentiate this from the megacisterna magna. So here, then Dandy-Walker, as we said, enlarged fourth ventricle, vermis problems, and a large posterior fossa cyst. In enlarged megacisterna magna, the cerebellar vermis is normal, ventricular system is normal, but there is a large cystic lesion in the posterior fossa, is megacisterna magna. Might be another variation of Dandy-Walker, but here the cerebellar function and cerebellar structure is preserved. So long-term implications are less compared to the just isolated, compared to the Dandy-Walker. So all these babies will be needing further neuroimaging with more detailing. But when we see babies, we have neurological symptoms in the newborn baby, or we come across babies with hydrocephalus in the first scans, we can, as a bedside ultrasound scan, we can look into these structures that might guide us towards the diagnosis. So yeah, so we talked about whether we want to see is a ventricular megaly or not, which type of hydrocephalus, any association with the congenital anomalies. And so we sort of comes to a picture what we are dealing with and what next. So here clear protocols, which I think I'll post it in the group together for you. Good articles done by Levine and Davies, and the recent study from the group in the Scandinavian. They're given clear-cut criteria where we, depending on the ventricular size and the anterior horn width, we can see how frequently we need to measure, what are the clinical signs that we need to look into, what management pattern that we need to be following when they need intervention. Say like a traffic light signal, green, yellow, red. So using these criteria, we might be able to provide appropriate clinical management to our patients in front of us. So yeah, I think that's where I want to conclude. I hope I've given some overview of how to measure and have a structure in our head, how to come across when we see a baby with ventriculomegaly. And then further, I think we can put it for discussion, or Dr. Alok, anyone wants to add anything to it, please chip in.
No, thank you, Ranjit. That's a fantastic presentation. I was going to open the floor to any questions. So, guys, do you have any questions? You can ask them. So what we will be doing is, obviously, the different...
Okay.
Yeah.
Thank you very much for your presentation. It was so lucid. I just want to clarify how to identify the difference between actual ventriculomegaly, secondary to hydrocephalus, and other causes. Thank you.
Yeah, I'll see if I can touch that a bit more in the... Alok might be ready to step in as well. I'll go back to the picture what I was trying to talk about. Yeah. So basically, we want to see whether it is because hydrocephalus, because of the ventricular internal ventricular system problem, or because of the external parenchymal thing. Obviously, if you see the internal ventricular problem, we have increased pressure from the ventricles. We have ballooning of the ventricles, as we see here. Because the parenchyma is preserved, the midline structure, the intercerebral fissure is not very prominent. This is one way that we can identify it's a ventriculomegaly, not ex vacuo. Here in this C, there is no ballooning of the ventricles, and the intercerebral fissures are very prominent, saying thus there is a loss of the cortical matter here that is causing negative pressure to pull the ventricle, to make the ventricle looks dilated.
So just to add that clinically, when you look at these babies, often what you'll find is that with hydrocephalus, an enlargement of the ventricles, you'll get clinical signs to suggest hydrocephalus, tense fontanelle, really sutures that are splayed. You might lose your superior sagittal sinus kind of pulsations. And in addition to that, when you measure head circumferences, they'll be going up. But in hydrocephalus ex vacuo, often what you have is an element of cerebral atrophy, which is why the ventricles are prominent. So not only are the extraaxial spaces quite prominent, but the head circumference you'll find will not be going up significantly. It might be constant. So you must always clinically correlate, because it is also well known, and I will show you a case on Sunday where you can have hydrocephalus with quite significant ventriculomegaly with raised intracranial pressure, which becomes arrested because you're able to basically have flow through the ventricular system established. And that, from our perspective, helps and causes the hydrocephalus to start settling down. But at the same time, ischemic injury to the brain has happened. And because of this ischemic injury to the brain, what happens is you start developing cerebral atrophy. So you can have a combination of both. And I've also been in the situation where we've diagnosed hydrocephalus ex vacuo, where we think there is significant cerebral atrophy, only to realize that actually this baby had an infection, maybe possibly an episode of meningitis, developed obstruction of the ventricular system because of, erosion of arachnoid villi or potentially some other inflammatory exudates accumulating. And that baby can go on to develop hydrocephalus again. So what I would say is that you need to be able to clinically correlate, monitor the baby's head circumference, and look for signs of raised intracranial pressure. And please be aware, signs of raised intracranial pressure may not necessarily just reflect ventricular pressure. You might have a baby who, say, for example, has had a large IVH which is getting absorbed with significant midline shift. So the parenchymal involvement and edema of the brain can also give you raised signs of ICT, and your ventricles may not necessarily be dilated. So very important to, uh, kind of look at your scan, look at the baby, and make interpretation. Any other questions?
Are those dark areas at the bottom, are they fourth ventricles dilated?
So, Ranjit, asking whether you can see the fourth ventricle in this image. You can't.
You can't.
So,
We will be using the third ventricle that we are looking into.
So when you look at the midline views, Sylvian fissures, you can see classical Sylvian fissures, you can see dilated ventricles, and really with the dilated ventricles, you basically have the foramen of Monro, which may or may not be blocked with a dilated third ventricle over here, which kind of indicates there might be a blockage below that. But in this view, seeing the fourth ventricle is very difficult. You can see the fourth ventricle only in the sagittal views well, midline sagittal view, and then really in the mastoid view that you saw Dr. Hassoun show it today. But the best other view in which you can see the ventricular system with lateral ventricles, third ventricle communicating with the fourth ventricle is actually going to the temporal and mastoid views and trying to get a linear image. I will talk about it in mastoid views. Any other question? I'm going
Can you show the Dandy Walker again, the image?
Go to full screen, Ranjit.
Yeah. So one of the things I was thinking about is the differentiating between Dandy Walker with the complete absence of cerebellar vomis or only isolated megacisterna magna. They have very different prognosis. Here in the midline sagittal view, we have the fourth ventricle, which is bigger, dilated. Cerebellum is partially absent, only little part you can see. And there's a space here in the posterior fossa, which might be a cyst or which might be a dropout, might be the depth sometimes we need to think about. But there's a big cystic lesion here with enlarged fourth ventricle and absent cerebral vomis is a typical triad for the Dandy-Walker malformation. If you go to only isolated megacisterna magna, probably it will be look like the cerebellar hemisphere and cerebellum vermis is preserved. Fourth ventricle is not dilated. So this part is normal. Only we see the cystic lesion in the posterior fossa, which is megacisterna magna. If that is what you're asking, Dr. Anna?
Yes, thank you. It's clear now.
Time for one last question. Lovely. I'm going to thank you all. That was lovely, Ranjit. Thank you so much for an absolutely fantastic presentation. I think now what I'd say is that for all of you, we are going to talk a lot about measurements. We've talked about measurements, but some of the scans that we will discuss. So again, what I'd say is a good opportunity for you to start doing measurements and really, again, thinking about the anterior horn measurements, measurement of the third ventricle, lateral ventricles, Levene's index, thalmo-occipital diameters. So where possible, even if you have a normal preterm baby, I want you to practice doing it just to make sure that you're actually getting it right. So God bless you all, and thank you so much for today's session. Thank you, Ranjit. Really kind of you.
Thank you, Alok. All the best, everyone. We'll see you again.
Thank you.
Thank you very much.